All right. So today we have a very interesting presentation that I think a lot of folks will be interested in, especially some of the technical side of it, because a lot of folks are interested in spatial analysis, but also some of the underlying things regarding access to care. I'm going to ask if Sid, who's joining us online, welcome back, Sid, has anything else to share to couch this or frame this for our Gemini folks before we hand it over to Ankit.
Yeah, sure. Well, thanks, Ashley. It's not as good as 70 degrees here. It's still 40 in New York, so it's pretty chilly. But Ankit has been a long time volunteer working with us at oh, I'm getting feedback. Okay, working with us at Asar. He is an engineer by training, uh, and I think what he's going to talk about today is less on the analysis side, but more. I think like a weird feedback.
You're good, Sid. It might help if I turn the volume down in the room because it's really loud, but you sound okay though. You're just loud.
Okay, cool. But he's going to talk more about dealing with kind of incomplete and inaccurate data in a lot of low and middle income countries, with India as an example. So yeah, he's going to talk about kind of like small things that all of us have to be careful about when we are working with sort of data quality compromises while doing spatial analyses. Yeah, that's mostly it. Over to you, Ankit.
Go for it, Ankit.
Hello everyone, my name is Ankit Raj. I am a first year master student at Pratt School of Engineering, and today I'll be talking about building geomaps and for healthcare in India. And yeah, let's start. So the motivation for this is, as you can see, there are a lot of tragedies inside low-income countries that can happen if people don't have proper access to healthcare facilities. Now, the geographic access to healthcare facilities is somewhat coined and termed as moral capital in some systems. And to explain it out in a more defined format, we can separate it into three parts. First, we have the facility density itself that are distributed across the country, and then we can have the timeliness to these facilities. Then comes the population density itself, and then when we combine all three of these factors, we can actually calculate the population density that can access these healthcare facilities in due time and using different methods of transfers. Now, Indo-Map is a project that covers mostly this, and today I'll be talking mostly on the data collection side of things, but if you are interested in data analysis as well, please scan the QR code as shown, and it will be accessed. So giving you a basic general data background of what we are working with. We are working with a large data set, or a combination of a large data set that we have scraped and acquired from various sources. So as you can see, we have 10 plus data sources, and we have been working on it for quite a long time. A lot of people have put in their efforts as well. So going through the data sources itself, we mainly acquired it using official government portals. So I'll name some of them. CDAC, that is Central for Development of Advanced Computing, is a tier 1 organization that is a scientific society under the Ministry of Electronics and IT. And then we have some government plans like Pradhan Mantri Jan Arogya Yojana portal that translates to Prime Minister Public Health Wellbeing Plan portal, and then we have Pradhan Mantri Gram Sadak Yojana, that is Prime Minister Village Road Building Plan. Then we have National Health Profile, that is a publication given by Central Bureau of Healthcare, India. And then we have Niti Aayog and National Health Association as well. So these are some of the data sources where we extract our data. As you can see, we divide these data in different parts, as in what kind of services or facilities these healthcare centers provide. So there are blood banks, there are primary healthcare centers, there are community healthcare centers, there are medical college hospitals, district hospitals, and combining all of them together, we can build a proper comprehensive directory. So as you can see in the slides on the bottom part, we have primary healthcare, specialty healthcare, and healthcare networks. So these are basically different kind of services that these healthcare centers can provide, and yeah, we take note of different kind of properties these data points can provide us and combine them all together into our data dictionary. Going on, we have made a proper data processing pipeline that we use now, and it has been built over the years, combining different techniques as to how we look at the data, what can we understand from the data, what do we want from them, and figuring out different anomalies that we find along the way during the analysis itself. So first we come to the data collection part. So we either import the data itself, we either use API integrations using different portals, or we scrape the data entirely from the website if it's available. And now we have the raw data set, which yes, have multiple issues and it cannot be worked with because government data are not exactly very reliable. We go to the data cleaning and sanitization part. So these are some of the overall processes. I will go into them one by one and explain in detail of how they work. So data collection process, as I explained, the collection process is quite simple. We configure the headers if we are integrating from the API or if we are fetching it from the website itself. So we set a rate limit as well of how many requests do we want to send from the API in order to don't overburden the servers that we're fetching from. We have some error handling as well because we don't want the process to crash in between. So we have those. We paginate the data as well. So let's say we take 100 pages of data and then we keep on collecting them, keeping them in separate parts, and then we combine them all together. Now, most of it is just parsing the HTML page if we are scraping, and then we check for the fields that we require and we scrape them, and we try to format them into the CSV file directly. Now that we have the raw data itself, now it's time to clean it and standardize in a way that we want in our master data. So we'll remove, it's a very basic process of removing special characters, standardize the cases, remove special cases, and handle abbreviations as well. Now moving on to the deduplication part, we have fuzzy matching. So we check for duplicates inside the data sets itself, and if we are working with multiple data sets, we also try to deduplicate them if they are in the same context. We standardize the data into a particular format, convert the data types, and validate again that the range of these fields are within acceptable limits. Now, coming to the geolocation part, we have coordinates of these healthcare facilities, and we try to make sure that these coordinates are as accurate as possible. Now, some of the coordinates are not exactly very accurate. Now, reason for them not being accurate are not exactly known, but we try to fix them from our end. Now, how we do that is, first of all, recognize the problem itself. Um, what we do is we use Google Maps API to geolocate the data. So we use the name of the facilities and the address to get the data, get the coordinates, and then we put them on a graph and see if they are aligning or not. If we have outliers, as you can see, they are not exactly on the line and they deviate a lot from the line. So these are outliers which we need to fix. Depending upon the quality of the data sets, we will have different number of outliers that we need to fix. And then we move on to the geolocation section. What we first of all do is take the fields of coordinates and match them directly with the coordinates that we got from the Google Maps API. Now, if both of them are in a valid format that we have got, then we move forward and check the range of them. Now, since we are doing this in terms of within a country itself, we check the boundaries so as to not go outside. And we keep moving forward to, since we do this in batches, we send Google Maps request and keep doing this and standardize to a given decimal format, to a decimal place, so we have an accurate range of coordinates. Now, we do reverse geocoding as well, since we don't know if the addresses are validated or not. Because we need to do that. And how we do that, we take the coordinates itself and then we send it to Google Maps. Now, what we get is a name of the facility and the address. Now, we fuzzy match it with our own, what we have from the data sets, and if we have a proper match, then it's good. If not, there's an outlier that we need to fix and we just flag it that we need to take care of it on the data stages. We then move on to again check the graphs so as to check if we are looking at outliers that we have somewhat missed. If yes, we go back again and manually fix them. So coming to the verification part, after we are done manually fixing all the geocodes, we make sure that we have standardized the names of the states, districts, everything as per the LGD codes. LGD is a local government directory code that is standardized across the government. Surprising thing is, even though these data sets do come from government, they are not up to the LGD codes and formats. So I don't know why that is. So we make sure that it's in a standardized format. Now we have taken this LGD codes as a source of truth for in terms of names of districts and states. Moving on, what we try to do is flag problematic names and of states and districts that we have come across multiple times, and we try to document them so as to take care of them in future if we have similar problems or not. So yes, and this is a representation of healthcare distribution across India in SHP files. This is a state SHP file, so we have state distribution. One is medical college hospital, so you can see the density is quite less. It's almost 648, so very sparse distribution. Whereas for the blood banks, we have around 5,600 something blood banks, so it's almost 9 times. So, and as you can observe, a good way to indicate that yes, this distribution is correct in a way. We just try to apply common sense in terms of how the population density in certain areas is big, is high. So the healthcare facilities in those areas are also high. As you can see in the middle, we have Delhi. So the population density is extremely high, and we have more blood banks over there. As you can see, whereas in Rajasthan, it's a desert area. The population density is extremely low, and in terms of difficult terrain, the population density decreases, so as the healthcare facility distribution also decreases. Now, we keep a note of such districts and states that have been newly formed and are not present in the data sets itself. So we'll have ambiguities of saying, let's say, hey, in the LGD codes, we have a different name of the district, whereas we'll have a altogether different name in the data set. So we take a note of it and we try to understand as to why this happened, and we document all of these steps and flag them basically for future references. Now, right now, IndoHeal is going well, but we don't have a proper, robust pipeline for it. We do have the codes, but we do have future plans for it as well. So what we're planning right now is a software as a service platform, which will handle everything from top to bottom. As we move back in these slides. So this entire thing would be encapsulated inside the service as a platform. We have named it IDLI. So India Dictionary Library, as if I remember correctly. And we'll try to implement this as an open source resource for people who try to work with healthcare data a lot. Because this is something that we encounter on a daily basis, and we don't want to go back to non-reliable solutions on an everyday basis. So we're trying to make sure that we have a proper, robust pipeline which will handle the data collection, query, visualization, processing, all at one place, and should be helpful to anyone who is working with healthcare facility data. And we have a bash script version as well. It's like a lightweight version, so you just download it and you should be able to just put in one command and you should get all the data itself. But it's more for an engineering side of project. It's not entirely very user friendly, as you can imagine, because it's just a terminal facing. And if you are interested in more information about these projects, please use and scan the QR codes and be redirected. That will be it. Thank you.
Awesome.
If you have any questions, please.
Yeah, please share if you have questions or comments. You can drop in the chat or unmute. Welcome.
I can start. So this is very interesting, and I'll preface that I'm not a data science person, I'm a clinician, and so I think what I was most curious about is this data seems very robust, like there's a lot of really good information, kind of where stuff is. How do you envision that going forward, maybe being like helpful to the health system or to people on the ground, or do you envision it more at like a systems level? I guess like at which point of integration do you think it'll be the most useful? Does that make sense? Okay.
Yes. So from what I know, I think it's more a systems level. It's not something a person on ground would be very familiar with. But let's say if someone is really interested on knowing about their locality or their general area of how well developed they are in terms of healthcare facility distributions, then they can check it out, because the platform I was talking about earlier. So it would provide you those information if you query. I think Siddesh would be able to explain it in a much better way than I would.
But it was very impressive to see just like the amount of data that you guys were able to process and go through and present in a way that makes sense.
Yeah. You came off mute. Sid, did you want to add something?
Yeah. I think, I guess, wait, was it like Sharla asking that question?
Oh yeah, sorry, maybe I don't.
Yeah, awesome.
That was Charla. I said.
All right. Yeah. Hey, I think there are like I think we look at it two ways. So like the platform that Ankit mentioned at the last, we are trying to build that more as like public facing platform that people can use to look at how healthcare access is, how that pans out in like their like localities. But then the other side of this is also to sort of use this to communicate to like health planners and like policymakers, uh, in order to help them figure out which might be new places for expansion. So we have, for some states, we have something called accessibility deserts that we have mapped out. And so these are probably the places where, like the state governments want to put in more money to have newer centers. One of the places where Joao and I have been using this is also that in one data set of like all the different data sets that Ankit like showed, we have about 700 district hospitals, and these are publicly funded hospitals where anyone can get care for free. These are supposed to be also like first level surgical and cancer care hospitals. And the government literally last week came up with a new budget to fund 300 of these to upgrade their cancer care. And one of our colleagues at USER is trying to work with the government to figure out which 300 they should pick out of the 700 so that we have optimal like timeliness access for those. So yeah, I think there are like way more use cases here than we can right now think of, but having the basic infrastructure would be really interesting and useful going ahead. So yeah.
Other comments or questions? Anything else to add?
I think it's a bummer that Joao's aren't here, because it just
I
reminds me a
know.
lot of the like Brazilian data mapping, I mean, like as someone who doesn't like, just the way it's presented and like using large data to tell a story with map, you know.
Yeah, yes.
It's different, but yeah, that, I think it's, it reminds me of that, and I'm always just, like I said, impressed by people who can take just a massive amount of data and then like create it into a story and like a visual that seems like it could be directly helpful.
Yeah, we'll definitely, both Roz are traveling today, but we'll
Yeah.
definitely highlight this for them. And as Sid mentioned, you know, Joao Ricardo has been working on some of these collaborations, so. Yeah. Okay, anything else? Last call for questions or comments? Anything else to add or questions from you, Ankit or Sid, anybody? Okay. If not, thanks again for your great presentation and very interesting work.